Thank you so much. A lot more to think about. Moving on to our third panelist, Dr. Nikki Lurie. It's a pleasure to introduce her here. She was my boss for 8 years in her role as ASPR at HHS. She has actually contributed significantly to preparedness, both in terms of the right processes and innovative thinking in addressing that. And currently in her role as strategic advisor at CEPI, continues to do that. So looking forward to your thoughts, Nikki.
Thanks so much, Rima. It's really a tremendous honor and pleasure to be here and to share a panel and a room with KG and with Harvey, both of whom have just taught me so much and inspired me so much over the years. I think my comments and observations today will come from probably 4 sources, maybe 3. My work in ASPR over 8 years. My more recent work as the lead author for the Money and Microbes report from the World Bank. My work with CEPI. And I guess after listening to Harvey, I have to say that I came from clinic this morning, where I spent a half an hour through a Mandarin interpreter trying to explain the difference between the flu and influenza. Think about the standard 8-minute primary care office visit. It doesn't fit very well. So just for some perspective. So I'm going to take a slightly different tack than either Harvey or Gabrielle. I'm not going to focus on influenza. But maybe to say, first of all, that as a general observation much more globally, and I think you talked about this morning, outbreak preparedness priorities and needs and desires generally do not align with other country needs, especially in other countries. And I think you talked about some of this morning. Clearly around the world, more people die every day from hunger, from poverty, from violence, from routine infections like malaria or cholera, and increasingly chronic disease, non-communicable diseases. Even now in the DRC with Ebola, as Pierre Formendi pointed out to us a couple weeks ago, more people are dying from those things than from Ebola every day. So it's really hard to get that on people's radar screens. This isn't all that dissimilar from, as Gabrielle was talking about, the political and economic recognition in the 90s that the global HIV crisis really threatened to destabilize governments and our sort of global political order and seriously impede economic development. But it's fair to say still neither outbreaks nor non-communicable diseases are on the top of mind. And frankly, most days they're not on the top of mind in the US either. So I don't think we need to go pointing fingers at the rest of the world for this. But it's also the case that we rarely speak of these things in the same breath. And having looked at this now, I would argue that you need a pretty generic skill set to deal with both of them, from a workforce perspective, from an infrastructure perspective, from a public health perspective, at least as those things are the first line of defense. Right now, we have a situation where outbreak-related research, especially in developing countries, is not a very sustainable endeavor because it's one disease at a time. When that disease goes away, although researchers need something else to do, and there's often not much to do for them, and so the infrastructure disappears. And yet the non-communicable disease needs and capabilities are often the same needs and capabilities you need to have to respond to basic elements of an outbreak. And we don't talk about them that much in the same breath. So as we talk about priorities for investment, I think we ought to be thinking much more broadly than emerging infectious diseases about how those investments could be multi-purpose, linking the capacity building efforts to outbreak preparedness so that we're really addressing the day in and day out issues of the governments at hand rather than the interests of others. I mean, right now, so much of the work is funder driven, as I said, goes away after the disease du jour is quieted down, and we can't keep doing this. So then, with that as a little bit of a prelude, what about outbreak preparedness? A couple of things that I learned in ASPR that are really important. First of all, you have to build on day-to-day systems, and you respond whatever you have in place when the outbreak happens. You can't respond with the system you wish you had or with the vaccine you wish you had. Second thing is, never let a good crisis go to waste. So what day-to-day systems do we need to build on to be outbreak ready? Harvey laid out a terrific agenda of vaccines, diagnostics, and antivirals for flu, and that goes for other things as well. So I'm not really going to talk about that as much as I expected Harvey would cover that well. We all talk about surveillance, and I'm not going to talk that much about surveillance either, other than to say we need a much more multi-purpose surveillance system that we have now. The same skills that do outbreak surveillance, do hypertension surveillance, do diabetes surveillance. These are the kinds of things that increasingly are killing people around the world, including in developing countries. And that system, if it's robust and flexible, needs to be able to pivot to detect a signal in an outbreak and to respond to an outbreak. Even in the US, over the time that I've been in preparedness, almost all of the funding for surveillance has shifted to a preparedness budget, and that is sort of being jiggered all the time to do all the other disease surveillance. I think we have to take a really hard look at how we organize that. Second thing would be health system strengthening. Much of the discussion here has been about the aspects of health system strengthening and that are about screening and prevention. But frankly, also critical to outbreak preparedness is the ability to deliver basic medical care. Whether it's in influenza, where we saw that large parts of the world are really unable to oxygenate a patient using oxygen, or in Ebola, where we found that Ebola-affected countries were not able to manage basic fluids with IVs. So there are some really basic things that we take for granted here. I'm not talking about primary, I'm not talking about quaternary care or tertiary care. I'm talking about basic stuff. And when we go in and respond to an outbreak now, when is it that we look at the health system and say, my gosh, we can't wash our hands, there's no IV fluids here? Work acutely to either try to fix it or in the learning window that happens after every outbreak, think about how to strengthen that. I think the US is especially guilty in this regard. I'm very struck by the fact that our European colleagues are all over trying to help clinicians in developing countries learn how to strengthen their basic clinical skills. Maybe because we don't have a healthcare system, maybe because our NIH and our healthcare system are really divorced, and our public health system and our healthcare system are really divorced. We don't focus as much on that, but I think it is a real need in the developing world, and we haven't talked very much about it. So I wanted to highlight that for sure. One of the questions I think about this session was about the business case for investment. At the end of the day, we all know the business case just for outbreak preparedness doesn't work from behavioral economic terms, from political terms, for anything else. But I think if you tried to put together the business case for all these things that are killing people and built in the business case for responding to non-communicable diseases and those core skills at the same time you did the business case for outbreak preparedness, we would probably find that the equation looks different for countries, that countries themselves might be more willing to invest in a more generic skill set. And framed appropriately, I think it could attract a lot more private sector interest and push, both from an emerging markets perspective and because private sector parties investing in developing countries need there to be a much more functional surveillance and health delivery system. So this is probably not what we typically talk about when we talk about outbreak preparedness, but we keep doing the same thing over and over and over again. My friend Bruce Skellen used to say, we do the same thing, only louder. We're doing the same thing here, only louder, and I think we have to do things differently if we're gonna be successful. So while probably not popular, it's also a really fair question, I think, for us to ask whether in aggregate more money is needed, to Gabrielle's question, or whether we need to be using that money differently. And so again, when I worked on the Money in Microgrowth report, one of the things I was struck with is that there was a ton of money going into capacity building, to outbreak preparedness, to all of this stuff. Funders are sort of tripping over one another. It's really stovepiped by disease. They're often unaware of what one another are doing. They're totally unaware of what's going on in the private sector and vice versa. And so I don't think that we are getting the kind of synergies we need out of this funding to get to the optimal results. And we need to think about how to get ourselves there. So at a minimum, I would argue we need some transparency about who's doing what, so the funders themselves can organize themselves better and do better. And then we need to make it easier on the countries to deal with loads of funders. From the IVTF report, I learned that we had about 1,000 funders in this space. 8 to 10 of them cover about 85% of the territory. So I think we could start there pretty easily. The third thing I really want to talk about then, in addition to the priorities on surveillance and health system strengthening and getting our money organized, is something that many of you have heard me say before, and that's making research part of every outbreak response and having the preparedness to do research be part of our outbreak preparedness going forward. With every crisis that I've been involved with, we have missed important opportunities to ask and answer important questions. And with any new outbreak, we're going to have a new disease, we're going to have things we need to know about it, it's not going to be well understood, and we'll ask and answer those things too late. And that will continue to be something that hangs us up unless we do something physically different. So we need an organized system for doing it. It's not going to be a surprise what the major research questions are going to be, and it's not going to be a surprise that we're going to need to do some convening to get the world together to figure that out. What have I got? 5 minutes. Okay, to figure that out. And so we are to think about what are the basic research capabilities we need? What are the basic research questions? Just like we do in the rest of preparedness, build a system to develop those research capabilities so we can execute them when we need them. I understand you all had a conversation about making money flow quickly. That's really, really important. I think the preparedness, the reserve fund, is a great step forward in that regard. And there needs to be both a national system and a global system of making funds flow quickly. WHO shouldn't have to pass the hat for 6 or 8 weeks each time there's an outbreak in order to get things going. And then finally, there needs to be a good system of global governance around research. I think WHO efforts around the blueprint are a really good start, particularly as it reflects the needs of sovereign countries. But it needs some more work, and it's going to need to be a much faster process and more nimble process if that happens. I think CEPI has made a commitment to fund research that's in the critical path for vaccine development, and that's an important thing. 3 other really quick things that I want to focus on. 1 high-tech, 1 low-tech, and 1 just hard. 1 is the role of culture. In every outbreak, as Harvey says, you need the public with you. In every outbreak, whether it's here in the US or in a developing country, understanding culture, beliefs, knowledge, attitudes is central. If you talk to WHO leaders now, they'll say, I don't even want epidemiologists, I want anthropologists and social scientists to help me understand what it is that we need to do to engage the population productively in outbreak control, maybe accepting vaccines, maybe using an at-home diagnostic, whatever it is. We don't have a ready workforce of those people right now like we can deploy epidemiologists. The second is a vaccine-related issue. I think it's very exciting to see CEPI moving forward and developing novel vaccines and platforms. Remember, CEPI's mandate is to take vaccines up through phase 2 and then potentially test them in an outbreak. Well, let's say one works. As to Harvey's point about being able to produce billions of vaccines quickly, we have no system to do it, and we have no market case at all for these companies that we're going to ask to make small amounts of vaccine really infrequently when they're in a stockpile. So we need to think very differently about nimble, sustainable manufacturing capacity that's hopefully decentralized in different areas of the world. It's going to be a big investment. It's going to take a lot of creativity. But that's for when Harvey does his next review time horizon, if not longer. The last point I would make, and I think it's one that you all talked about earlier, is that I do not believe that there is a single person in the world that knows end to end what is supposed to happen and how it happens, from the time a new virus is discovered all the way through PIP, to sequencing a gene, to sending to a manufacturer, to making vaccine, to deploying it, et cetera. If I think about H1N1, when we wanted to send vaccine to other countries, it took 6 months and 68 different steps you had to go through to do it. Nobody knows all of the systems that are involved. Nobody who's going to be overseeing this whole thing knows all the systems that are involved, even for making vaccine. The vaccine manufacturers do, but the rest of us don't. So somehow better understanding and visibility on all the moving parts, exercising them somehow as a whole makes sense. So summary priorities for me, short term, training deployable teams of social scientists, research preparedness, multi-purpose health system strengthening, and then longer term, sustainable, country-owned, deployable vaccine manufacturing, and clarity, about the business case for multi-purpose strengthening. Thanks. I did it in under 15 minutes. Right.
Very good.
Good.